Tetrodotoxin, a potential drug for neuropathic and cancer pain relief, by Elizabeth Cliston, Sandy Edwards, and Nate Bevar. Tetrodotoxin is a potent neurotoxin found in pufferfish and other marine animals such as salamanders, frogs, crabs, sea stars, and some snakes. Possible exposure could be from eating improperly prepared fish or eating contaminated food products. To the right is a pyramid demonstrating how the pufferfish becomes exposed to tetrodotoxin, or TTX. Pufferfish initially acquire the TTX-producing bacteria, seen at the bottom of the figure, via the food web, and these bacteria then persist in the fish.
Tetrodotoxin is a potent neurotoxin that produces severe toxicity that can lead to death. It is 120,000 times as deadly as cocaine and 40,000 times as deadly as methamphetamine. Symptoms can begin within 30 minutes. There are 4 grades of poisoning based upon dose. Grade 1 symptoms are paresthesia and perioral numbness, nausea, vomiting, abdominal pain, and diarrhea. Grade 2 is facial numbness, slurred speech, early motor paralysis, incoordination with normal reflexes. Grade 3 is generalized flaccid paralysis, aphonia, respiratory failure, fixed dilated pupils in a conscious patient. And grade 4 is severe respiratory failure, hypoxia, bradycardia, cardiac dysarrhythmias, and unconsciousness leading to death.
TTX is a potent non-peptide guanidinium neurotoxin that blocks voltage-gated sodium channels. Voltage-gated sodium channels play an important role in pain. They can be found in the peripheral and central nervous systems and are responsible for generating the sodium currents that lead to the initiation and propagation of neuronal action potentials. How does tetrodotoxin block voltage-gated sodium channels? First, TTX binds to voltage-gated sodium channels by the interaction between the positively charged guanidine group in the TTX molecule with the negatively charged carboxylate residues that are placed around the outer vesicle of the channel. The TTX then occludes the pore and completely blocks the sodium current. As a result, sensory receptors are blocked and action potentials are prevented, and this causes paralysis, numbness, and rapid weakening of muscles. Chronic pain conditions can be a consequence of abnormal functioning of the nervous system. In particular, neuropathic pain arises from a lesion of the somatosensory system at the peripheral or central level. Central neuropathic pain is a result of injuries to the central nervous system, such as a spinal cord injury, a stroke, or multiple sclerosis. On the other hand, peripheral neuropathic pain is the result of injuries to the peripheral nervous system that could come from metabolic disease, injections, mechanical trauma, and chemotherapy. What we are going to be focusing on more in depth is cancer-related pain. Pain caused by cancer frequently presents a mixed pathophysiology, including both nociceptive and neuropathic components, depending on the progression and extension of the tumor. Cancer patients with neuropathic pain usually have more trouble optimally controlling pain, and the effectiveness of available drugs in the treatment of cancer pain is very low. It's also often very difficult to differentiate between acute and chronic pain when it comes to cancer-related pain. The difficulty in optimally treating these pain conditions has prompted significant research into new analgesic agents.
Now we will talk about the role of tetrodotoxin in the neuropathic pathway as well as in its interaction with cancer pain. So most voltage-gated sodium channels are located at the peripheral and central nervous system. They are responsible for generating sodium currents that lead to the initiation and propagation action potentials. When the tetrodotoxin binds to the voltage-gated sodium channels, the TTX molecule is positively charged, which binds the negatively charged carboxylate that are found around the channel. It binds the sodium channels on the nerve cells and blocks the sodium channel from opening, therefore blocking the sodium current. NAV 1.1, NAV 1.2, NAV 1.3, NAV 1.4, NAV 1.6, and NAV 1.7 are sensitive to being blocked by small concentrations of tetrodotoxin. NAV 1.5, NAV 1.8, and NAV 1.9 are tetrodotoxin resistant. So, tetrodotoxin has potentially therapeutic effects, one being an analgesic effect. This effect is caused by the binding of tetrodotoxin to the alpha subunit within the other vestibule of the voltage-gated sodium channels, blocking the entry of sodium ions. This reduces the sodium ionic activity, restricting the conduction of nerve impulses. The reduced entry of sodium ions at these subunits, which culminate around injury sites, produces a decrease to pain sensitivity. This is what causes the analgesic effect of tetrodotoxin. During pathological pain conditions, which could be due to damage to the nervous system within the brain or spinal cord, there is an upregulation of voltage-gated sodium channels NaV1.3 subtype, leading to neuronal hyperresponsiveness. Dysfunction causes epilepsy, migraines, and neuropathic pain. Again, NaV1.7 is sensitive to tetrodotoxin, and this subtype plays a critical role in the generation and conduction of action potentials. Therefore, when blocked, the excitability of sensory neurons are dysfunctional. NaV1.6 subtype is sensitive to tetrodotoxin and is widely expressed in the central and peripheral nervous system, regulating neuron excitability. So when blocked by tetrodotoxin, dysfunction of the NaV1.6 subtype can lead to epilepsy, intellectual disability, and movement disorders. Tetrodotoxin-resistant voltage-gated sodium channels are also involved in some pain conditions. NaV1.5 is the primary sodium channel expressed in cardiac muscles, but it is not sensitive to tetrodotoxin, so its therapeutic effects is still being researched.
So, in order to fully understand the use of tetrodotoxin as a potential drug for pain relief, a series of trials was conducted on patients with both cancer-related pain and neuropathic pain. Based on the results, researchers would be able to identify the benefits of utilizing tetrodotoxin within the clinical field regarding cancer and neuropathic pain suppression. So the first clinical trial utilized a multi-dose efficacy study, which involved 24 patients, each patient being administered tetrodotoxin intramuscularly. There were 31 sessions at doses ranging from 15 to 90 micrograms daily. The doses were divided up 2 or 3 times a day over 4 days. Well, based on the results, 17 of the 31 treatment sessions resulted in significant pain reductions. Pain relief persisted for up to 2 weeks or longer in some patients. With that, the authors ended up concluding that tetrodotoxin was effective and well tolerated at doses up to 30 micrograms a day, twice a day. The second clinical trial was a study conducted by WEX Pharmaceuticals Incorporated, which utilized a much larger and more randomized study, also involving a double-blind, placebo-controlled trial. So there was 82 patients which were randomized. 41 received tetrodotoxin and 41 received a placebo. Through the results of the previous trial, the doses of tetrodotoxin were given in 30 micrograms twice a day. Based on the results, there were more responders in the tetrodotoxin arm versus the placebo arm regarding pain intensity difference. The subcutaneous administration of tetrodotoxin indicated somewhat of a trend toward more responders in the tetrodotoxin arm versus the placebo arm based on the primary endpoint. Further analysis of the secondary endpoint suggested a robust analgesic effect if the composite endpoint was used. But overall, patients revealed the fall in pain level, a fall in opioid use, and just an improvement in quality of life. It was observed that relief was persistent within successive treatment cycles up to and beyond 1 year. So the previous 2 trials focused on cancer-related pain, whereas this one primarily focuses on neuropathic pain. The study was utilized to explore the safety and efficacy of several doses and dosing intervals of tetrodotoxin during 4 consecutive days. It was conducted as a randomized, double-blind, placebo-controlled multi-center trial. Within the study, there were 125 patients, all with neuropathic pain due to anti-cancer therapy. The 125 patients were divided into 5 dosing cohorts consisting of 25 patients each. 4 of the groups were given active tetrodotoxin, and 1 group was given a placebo. So based on the results, the authors revealed that 30 micrograms of tetrodotoxin gave the greatest change in average weekly pain scores at all time points tested. They also concluded that 30 micrograms of tetrodotoxin twice a day revealed the greatest number of responder, with a 30% reduction in pain severity within patients at any time point.